We are live. Good afternoon, and welcome to the Health and Government Operations Committee. We're going to do something different today and probably for the next few weeks because we only have 30-something days. Who's counting? How many days, anyone? 35 days left for session to end, April 7th at midnight. Can you please keep it quiet? Thank you. So we're going to have voting, we're going to have hearings, we might vote now twice a week, 3 times a week, subcommittee meetings at all times of the day. So I just want to thank the committee for being so responsible, for making this a priority and being on time so that we can start on time, all right? So we're going to start with voting, and then we have bill hearings after. So there are 2 withdrawals. Second. The withdrawals have been moved in second. Any questions or concerns regarding it? Seeing none, all those in favor say aye. Aye. Any opposition to withdrawing these bills? All right. House Bill 32, Delegate Charkoudian, Maryland Department of Health Forensic Review Board and Community Forensic Aftercare Program Establishment. It came out of subcommittee favorable with amendment. It is Aaron and Bagno, and I just want to let people know that we may go through these fast, but this committee vets every bill, I would say 99% of it, in subcommittee. So we have studied it, looked at it, and consider everything, okay? So, Aaron. You're gonna go. She wants to hold it. Delegate Bagno, you want to be recognized.
Yes, thank you, Madam Chair. We were waiting for some outstanding information on this bill, so we would like to hold it because it's not prepared for the voting.
We will hold it. All right. Let's go to House Bill 54. It is the departmental bill, Health Services Cost Review Commission User Fee Assessment Repeal of Sunset. It came out favorable out of subcommittee, and we have Aaron and Delegate Kerr. Aaron.
This is a departmental bill that repeals the June 3rd, 2025 termination date on the formula used to determine the maximum amount of user fees that may be assessed by the Health Services Cost Review Commission. The user fee cap will continue under this bill to be based on the 0.1% of budgeted hospital revenue or the largest cap amount determined during the immediately preceding 5 fiscal years.
Delegate Kerr.
Thank you, Madam Chair. It should be ready to go, so I will just go ahead and move the bill.
Second. Move the amendment, or move the bill, no amendments. Wonderful. So it's been moved in second. Any questions or concern on the favorable? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, the bill passes. Let's move on to House Bill 580, Delegate Hutchinson, Terminology and Obsolete References, Maryland State Firefighters Association and related terms. It came out of subcommittee favorable. It is Lindsay and Kerr. Lindsay.
This bill alters terminology throughout the annotated code so that references to the Maryland State Firemen's Association are replaced with the Maryland State Firefighters Association. References to the Disabled Firemen's and Rescue Squadmen's list are replaced with the Disabled Firefighters and Rescue Squad Persons list. References to firemen are replaced with firefighter, and references to squadmen are replaced with squad member.
Move the bill.
The bill has been moved in second. Any questions or discussion on the bill? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, the bill passes. Let's move on to House Bill 666. I do not like that number. Delegate Woods, Maryland. I know. I tell you, Maryland Medical Assistance Program and Health Insurance require coverage for calcium score testing. It came out of subcommittee favorable with amendment. It is Lisa and Vice Chair Collison. Lisa.
The bill requires carriers and Medicaid to cover calcium score testing for individuals in accordance with certain standards. The amendments are on the first page of your packet. They make technical changes, and they specify that the coverage is required in accordance with the most recent guidelines of the American College of Cardiology.
Okay, Vice Chair Collison.
Thank you, Madam Chair. The amendment and the bill as amended were both unanimous in subcommittee. I move the amendment.
Second.
The amendments have been moved and second. Are there any questions or discussion on the amendments? Seeing none, all those in favor say aye. Aye. Any opposition to the amendments? On the bill as amended?
Move the bill as amended. Second.
It's been moved and second. Any question or discussion on the bill as amended? Seeing none, all those in favor say, oh, Delegate Shalega, you got to get me really fast.
Yeah, sorry. You
It's
were
okay.
moving.
You're
This
good.
is an expansion of Medicaid services requirements.
Right, related,
Yeah.
right, related to,
And can't physicians do this without this? Couldn't a physician order a calcium scoring test without you doing this?
To answer. Delegate Woods would like to answer.
A physician can order it, however, it's not always been approved.
Okay. Yeah, I support what we're doing here, but just as a general rule, I'm going to be voting against expanding Medicaid. We have a serious budget problem, and, I hope all physicians order it, and, that obviously commercial payers are getting it paid for, and, this is a laudable good thing. I support the policy, but I'm going to oppose the expansion of Medicaid.
If I may, Madam Chair?
Yes.
I want you to know that we did the research. There's a very small number of people that would be impacted by this. Literally a very and I don't mean insignificant as the people, but an insignificant number of people who would be impacted.
Okay. Thank you, Delegate Shalega. Appreciate your thoughts. And Delegate Woods, thank you so much for doing the research. Any other questions or concerns on the bill? And we have moved it already, correct? Yes. All right. So all those in favor say aye. Aye. Any opposition, raise your hand, please. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, and all right. Okay. So now we're going to go, and thank you. Oh, yeah. All right, who does not want to be on the bill? Can you raise your hand? Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke. Thank you. And thank you for the discussion. Really appreciate it and welcome it. Yes.
Thank you, Madam Chair. I was looking at the fiscal note, and it says that Medicaid currently does cover this already. So I don't see that there's an actual expansion according to the fiscal note. It's saying that it's currently covered.
All right.
Yes, Medicaid does. Medicaid already covers it.
Move to withdraw the bill.
Okay. So I know the problem is that not everyone does it.
Correct.
Okay. All right. All right. Thank you very much. I appreciate it. It's great to have the discussion again. I welcome it. Next, we have House Bill 718, Delegate Rosenberg, Maryland Health Insurance Coverage Protection Commission established. It is favorable with amendment, and it is Lisa and Collison. Lisa.
This bill reestablishes the Maryland Health Insurance Coverage Protection Commission to monitor potential and actual federal changes to the ACA, Medicaid, the Maryland Children's Health Program, Medicare, and the Maryland All-Payer Model. The commission will assess the impact of changes to those acts and programs, and it will provide recommendations for state and local action to protect access to affordable health coverage. The amendments are on page 2 in your packet. They require the commission to monitor the Federal Mental Health Parity and Addiction Equity Act and add representatives of the Maryland Health Benefit Exchange and the Health Services Cost Review Commission as members to the commission.
Just a second. Michelle, can you send Delegate Ross an email, a text? I just realized. Okay, thank you so much. I know you probably did. You're ahead of me. Thank you. All right. The amendments have been moved. Moved in second. Any discussion or concerns on the amendment? Seeing none, all those in favor say aye. Aye. Any opposition on the amendment? On the bill as amended? The bill has been moved in second. Any question or discussion or concerns? Delegate Morgan.
So we had some discussion last night in subcommittee on this. This is the bill that we messed up on it. HSCRC. So they should be looking at federal law anyway, correct?
again.
I don't want to have the same discussion over. I just wanted to alert people what we
Right.
talked about.
Right.
Sorry.
No, I appreciate that, Delegate. The HSCRC's scope of work is limited to hospitals. So what they're doing is deciding looking at the utilization and of services in hospitals and making sure that the hospitals are receiving the funds they need to provide those services. What's happening outside of that is totally different. And so, yeah, they could be a part of it, and they are a part of it in the amendments, but they are just one entity, one part of our healthcare system.
So when the feds change something dealing with healthcare, and look, they've done this with every administration.
Right.
Who normally takes a look at that to see if, in the state?
I would say,
have we done it before without other commissions?
I would say that it's always been the role of the General Assembly to do that. Prior to the ACA, when the ACA became much more comprehensive and really sort of realigned healthcare, since then, we've been, having a much more comprehensive look with the first commission because of the changes that were happening between 2017 and 2021, and then, the concern of what's going to happen going forward.
Okay.
And if I may be heard on this, just because I served, and Delegate Kipke, am I right? Served on a similar commission when this happened in 2019, I think, 2020. And we will meet, I believe it was once a month. And the members, for example, are we had, of course, members from the Senate and the House, but we have the Secretary of Health, we had the Maryland Insurance Administration, we had the Attorney General, we had the Hospital Association, we have someone from the Consumer Healthcare Services. We had now MECA is going to be on it, and the carriers. So it's not just, it's wider than the HSCRC because their budget is limited and they can't take it. And I remember our discussions meeting once a month to see what changed and to be able to react, whether it was a lot of the legislative stuff came out of that commission, great, amazing bills. So it's basically more than just, watching what's going on in the oversight, but it's also being proactive as well. And then the HSCRC cannot do this job. And especially because we have, Delegate, a lot of waivers in Maryland when it comes to Medicaid, right? And we must pay attention to that and see whether we need to react, whether we need to come back, right? That is why this is really so important.
Okay, I won't belabor the point.
Thank you.
Madam Speaker, Madam Chair. I would just add that,
Madam Chair.
I'd add that, really the bill is looking at reforms for insurance and Medicaid and reforms in other health-related agencies. So no one agency could handle this. That's why we have this very diverse and inclusive group of people looking at it.
I guess the goal is, because we're hearing rumblings coming from the Medicaid expansion portion of it, because, in this bill, in the whereas clauses, it talks about that. In Maryland, where more than 600 people may become uninsured in the aftermath of the repeal of the ACA, I don't know how many people are talking about repealing the ACA at this point. Maybe portions of it with the Medicaid expansion, but.
And I hope you're right. But, I think.
Well, to be honest, both parties have been talking about repealing the ACA. There was a considerable push with the last administration to look at a Medicare for all.
But right now, I think what we want to do is make sure that the requirements of insurance carriers under the ACA are continued.
Okay.
The ones that are most important to us. Just to remind folks, it's, preventive services is no pre-existing conditions. There's no lifetime caps. Those are all new things since the ACA, and we want to make sure we keep them.
All right.
And for the record, Delegate, we're going to agree to disagree because I love you. But the Democratic Party, and we usually don't get here. I never get into the politics here. Have never argued to repeal the ACA. Medicare for all, Medicaid for all doesn't mean repealing. It means that, we want some certainty that everyone is covered right, as well. And we have fought very hard to preserve the ACA, but we're going to agree to disagree respectfully, right? But I do welcome it. Thank you. Thanks so much, Matt. Okay, Delegate Bandari.
Thank you. For the record, one of the great things about the bill is it recommends the legislative action to protect and expand access to health coverage as well, right? So, yep.
Delegate Rosenberg.
Thank you, Madam Chair. This bill is a deja vu all over again from 8 years ago, when there were also significant changes contemplated and implemented in healthcare. Thanks to John McCain, the ACA still lives. But wouldn't this also enhance, as the legislative body, our involvement should any changes be contemplated by the executive branch for fiscal reasons in response to what happens in Annapolis?
You mean our current, our state executive branch? Or-
Yes.
Absolutely.
Yes.
All right.
So it gives us that authority to be involved in that process by the creation of this commission, meeting on a monthly basis.
Yes.
Thank you.
Thank you. Look, there's just so much at stake. You know, in Maryland, we have 1.7 million people on Medicaid, and they come from all 24 jurisdictions. 700,000 of them are children. We also have insurance. We have 6 carriers in Maryland, right? And people that work hard and rely on their health insurance, and they need the coverage, right? We hear it every day here. So this is just a way to stay involved, because once we leave here, you know, it's easy to not pay attention, and this will keep it in the forefront, especially for this committee, because we're so intentional about that. But anyway, thank you for the discussion on both sides. I really appreciate it. Did I move the bill? Had I moved it? Okay, moved in second. Okay, all those in favor, say aye. Aye. Any opposition to the bill? Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Thank you, everyone, okay? I appreciate you. So let's go on now to, okay, who does not want to be on the bill? Can you raise your hand? Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. And the reason why, if you're wondering, I call out their name is not to pick on them or anything, it's so that staff knows and makes a point and the record is reflected appropriately, okay? So let's move on now to House Bill 930, Delegate Lopez, Public Health Abortion Grant Program Establishment. It came out of Subcommittee Favorable with Amendment. The analyst is Aaron, and the Subcommittee Chair, Bagnall. Aaron.
The bill establishes the Public Health Abortion Grant Program and the Public Health Abortion Grant Program Fund in the Maryland Department of Health to provide grants to improve access to abortion care clinical services. Excess funds in carriers' segregated accounts for abortion care clinical services under the Affordable Care Act must be used to support improving access to abortion care clinical services. By September 1st, 2025, and by July 1st, 2026, and annually thereafter, the insurance commissioner must order the transfer of specified funds from these accounts to the new special fund. By October 1st, 2025, the governor must allocate by budget amendment $2 million of these funds for the program. Beginning in fiscal 2027, the governor must include in the annual budget bill an appropriation for the fund of at least 90% of the ending balance of the segregated accounts that exceeds disbursements after the 15-month period following the end of a plan year. There is an amendment that was adopted in Public Health and Minority Health Disparities Subcommittee. The amendment clarifies the transfer of money required to be transferred on or before September 1st, 2025, includes the amount of interest that was accrued as of December 31st, 2024. The bill as introduced had an incorrect date, which would have been December 31st, 2025.
Delegate Bagnall.
Thank you, Madam Chair. We had a very robust discussion on this bill and a very respectful discussion about the fact that these funds are currently in a segregated account with the insurance carriers, that this is the only way that the funds are to be spent, that this is adhering to the federal law under the Affordable Care Act, and the bill did pass not unanimously. I would move the amendment.
So the amendments have been moved in second. I'm going to open it up for discussion or questions. Delegate Morgan.
On the bill, not the amendments.
Okay, so on the amendment, any questions or discussion? Seeing none, all those in favor say aye. Aye. Any opposition to the amendments? Seeing none, on the bill as amended. The bill has been moved and second. Questions or discussion? Delegate Morgan.
Thank you, Madam Chair.
You're welcome.
So we had some, I guess, internal discussions amongst ourselves last night at dinner, and we were talking about this, and I just want to make sure I understand the funding mechanism of this. So apparently, for the ACA has been law for about 15 years. So in the last 15 years, the carriers have been charging their clients, the payers, an extra $1 a month, and that money is going to a special fund to provide abortion services for those states that offer services beyond the Hyde Amendment. That's what. Yes, ma'am.
The floor leader to answer those questions, if I may.
Sure.
Delegate Lopez, will you be so kind?
Sure. That's about 99% correct.
Okay.
The part to probably flesh out a little bit is that each carrier has responsibility of their own segregated fund. So there's not like a fund per state.
Oh, okay.
It's that each carrier has been responsible for segregating these funds and managing their own, essentially.
How many carriers do we have?
We have 6.
6. I was thinking 8. Okay. So there's 6 separate funds in the state, and that totals somewhere close to 20 million.
25 million. And
25.
then that's the principal plus the interest. And then every year.
Can you speak up a little, please?
Every year subsequent, we can expect about 3 million to come into these funds.
Okay. Well, based on that, I mean, could we have I'd like to propose a conceptual amendment that this is a one-time disbursement and that we stop collecting those funds.
Well, that would be against federal law.
So it's federal law that's a requirement that these funds get collected?
In federal law, it is required of insurance carriers to collect these funds. If they do not collect them, then they run the risk of being decertified and having some type of civil monetary punishment.
So I find this hard to believe that this is federal law and it requires every state in the nation to do this? It's only the states that offer the services that can have, that doesn't make sense.
It's section 1303.
Okay.
Of the ACA.
Of the ACA, B through C, is with the discussion of segregated funds. And as a third-party verifier in this, the insurance carrier submitted a letter of information that outlines this as well.
Okay,
And
thank you.
Again, not taken a position, but they've verified that. We've also had the Attorney General provide testimony and a letter.
Okay, well, I appreciate my colleague for answering those questions.
This is the place, and again, I welcome it, okay? Delegate Chisholm.
Thank you.
Trying to give you space.
And I love it that both of you are right next to each other.
That's the reason why she doesn't use the microphone.
I love it, I love it. Delegate Chisholm.
And I heard her explain it yesterday, and I was still baffled by the whole thing, too. But one of my big concerns with the bill is the residency part. So non-residents have access to this. I understand it's a grant so that we can expand access, which includes, I'm assuming, providers, different, I guess, clinics. But I worry, we have a sex trafficking problem in this country, and I don't think anybody denies that. And if we're almost advertising that we are open for business for people in other states, are we then encouraging nefarious behavior, what has been I guess, identified by just about everybody on both, in both parties, that we have a serious problem. And are we now aiding that problem by saying we will, provide the abortions here? Because it's easy to understand when you're talking about sex trafficking. We're talking about, youth that are being exploited and then being brought to the place that it's easier for them to get provided an abortion without, I guess, without being identified as this person's bad. Like whoever's, it's horrible what happens to a lot of these young girls. Are we adding to that problem by not having a residency requirement here? Because if we know pretty much who our residents are, but if we don't know who it is, then I think it creates a bigger problem. And that was, obviously, I'm not going to vote for the bill, but that was a serious concern.
Sure. Thank you, Madam Chair. So in terms of residency, there's no precedence of requiring residency at the point of delivery of a health service. And that's a pretty problematic thing when you think about it, when it's applied. And so that's not a precedence we want to set with this bill for reproductive care or any type of care. If you go to the emergency room or you go to urgent care, we shouldn't ask if you're a resident of the state. We should be supporting the systems that provide you care. The second part of your question has to do with youth. We are a notification state, not a consent state, and that has been law since 1992. So if you are under 18 years old and you do not already have a child or you are not married, then you are required to, the provider is required to notify the parent that this is a procedure that's going on. And there are some exemptions, like if a parent is incarcerated or, there's some exceptions there, but we already have a system for notification of minors in this state that has been operating since 1992 without any complications. And so I would urge, I appreciate the interest for youth that are being trafficked, and certainly there's a lot of work that we can do to support folks in that space. But as it pertains to this bill, the language is fine as it is.
And if I may add to that, Delegate Chisholm, for a second, because it's tied up to the conversation, providers are trained to look for coercion, right? They're trained. We have done so much work on human trafficking that a lot of people are trained, right? Providers, people that work on, flight attendants, people at the school, because it is prevalent, right? So they're trained to do that. And not just that, they're trained to look for many other things as well.
And I appreciate that, and I wish I would have thought about it yesterday, but it would have been great to amend on the idea that with some of this grant money that we put in some of these clinics that assign, because I know there's organizations out there that do this. If you feel like you're in danger, you can be safe and call this number. And I know Vice Chair wants to, I guess, comment on that if she knows, if she.
Go ahead.
I think you answered the question.
Anything else? Okay. What was it? What was the question?
No, I would suggest, I wish we could have put that amendment on, but, and I don't know if it's too late to offer that money to have those signs put in some of these clinics that if you feel like you're in danger, we can provide a safe space. And I think, a lot of times what's waiting on the outside door is the same life that they're trying to escape, but they don't always feel like they can get out of that life. So to put that number up, because I know there's organizations out there that do this, that they try to stop sex trafficking and provide a safe place. And there's times that I know, because I know they do it in other places of the country, where they can get taken out the back door to somebody that can handle that situation for them, rather than just letting them go back out and get subjected to the same thing over again.
Delia Bagno and then Lopez.
Thank you, Madam Chair. And if I may, it wouldn't be appropriate in this bill because, once again, the federal law only allows for the funds to be used for services.
For what?
For services.
What kind of services?
For abortion, for clinical abortion.
Abortion care.
Abortion care.
Abortion care.
Yep, clinical abortion care.
Mm-hmm. Thank you. Thank you. I'm going to call on Hutchinson, who I saw first, and then Riley.
Thank you, Madam Chair.
You're welcome.
Two questions. First questions are, has the Attorney General and CMS ruled on this as to whether it's legal for us to pull these funds?
Delegate Lopez?
Yeah, you might remember from the hearing that the Attorney General's office came to testify on a sponsor panel, so they are fully in support.
Okay, how about CMS?
CMS, we normally wouldn't get their type of commentary on a state bill like this, so no, they weren't asked.
Okay, so my second part, and Delegate Bagnall, I did a little bit of research, and I was told that it's not just for abortion services, it's for reproductive health services. And I mean, that's what I was told by a very reliable source, that it's for reproductive health services, and we just enshrined reproductive health services in our Constitution. Reproductive health services is more than just abortion. So if it is for reproductive health services, why is this just for abortion and not for all reproductive health services?
Delegate Lopez?
Sure, I'm unaware of what source you're referencing, but I can reference Section 1303 of the Affordable Care Act, which explicitly says abortion care services, which our legal definition means clinical abortion care, and then service is about the administrative part of that care. So unfortunately, this bill doesn't cover the full spectrum of reproductive services, meaning cancer screenings, meaning family planning, STI screenings, things like that. It is very narrowly written in federal law. This can only be for abortion care services. And so, it is a big pot of money. Certainly, we have a lot of needs in terms of reproductive care in the state, but this bill at the federal level was only for abortion care services.
Thank you. Thank you, Madam Chair.
Thank you for your questions, Delegate Hutchinson. I'm going to go on next to Delegate Riley, followed by Shilega, followed by Hill. Delegate Riley.
Thank you, Madam Chair. Yeah, I asked several questions during subcommittee, so I'm not going to go over those. Thank you so much for providing those answers. But I did think of another one that wasn't asked yet. I'm curious, has there been any other states that have actually requested these funds and the funds have been dispersed to carriers?
Let me recognize
or
you.
Or to providers?
Delegate Lopez.
Yeah, Madam Chair. We would be the first in the nation to come up with the scheme of how to set up this grant program, but there have been other states that have used state funds, taxpayer funds, as stopgap measures. And so right now, the state that's probably leading in this way would be New Mexico. They are geographically located close to Texas, and so their abortion providers have experienced, I think, about a 250% increase in traffic from folks coming to Mexico, or from Texas over to New Mexico. And so they're trying to keep up with the demands. But unlike us, where we're using these surplus of insurance premiums, they're actually using taxpayer dollars to do it.
Okay, I understand that, but we use currently a lot of taxpayer dollars for abortion care and for clinics and for training. So I'm surprised that other states haven't done this. How did you know about this fund and actually to tap into it?
Well, I know some smart people, and they trust me, and we've been working on this for several years now. In 2022, we passed a package of abortion language, and part of that was having the Maryland Insurance Administrator audit these funds. And so for people who are in the reproductive care space, this is kind of an open secret. Members of Congress have pushed back on this from time to time, and so it's unfortunate we're accessing these funds now, but should have been done 15 years ago, perhaps.
That was kind of my follow-up question, Madam Speaker. Just why do we wait so long to access them? Okay, probably because we're familiar with it. Okay, and I think I'm good. Thank you.
So it's Maryland has come up with this strategy. And we don't do this with many bills, and where we're first, right? As well as the circumstances require it. I have next Delegate Shilega, I think, if I trust my memory, and then Hill. Delegate Shilega.
Thank you, Madam Chair, to the floor leader. So thank you for pointing us to the Maryland MIA report, which gives a little more information, but it does say that they've distributed some of the funds. Is that, I'm looking at a chart, receipts, disbursements, ending balance. So Have they been spending some of this for some purpose?
No, these funds have not been touched, as far as I know. I don't know.
Delegate Collison would like to shed some light. Is that okay? Will you yield for a minute? Thank you,
Those-
Delegate Collison.
Thank you, Madam Chair.
You're
Those
welcome.
funds were put there for abortion care for members of that insurance carrier. But $1 per member per month was a gross overestimation about how much money was going to be needed for these services. So it's a fund that can't be used for anything else, and it's just sitting in a segregated fund with each insurance carrier gathering interest with no
So the
purpose.
disbursement part is
For the members of
what
that.
they were paying for abortions for their policyholders.
Correct.
Okay, thank you. And the ACA Section 1303B-C, does every state do this as well? So do all 50 states, have they been charging $1 and
ahead.
accumulating money? Do you know?
Delegate Lopez? Sure. So abortion has been left to the states not only because of the Dobbs decision, but just in general when it comes to insurance. And so states who are offering or requiring abortion coverage be a part of the exchange plans are then required, the insurance carrier is required to take this money. But in some states, those state benefit insurance carriers do not cover abortion. And so in those states, they would not be required to segregate these funds.
Okay, so just to restate what you said, when the ACA was implemented, the states that chose to provide abortion as part of their mandated
Abortion care.
benefits were required to put this fee and fund in place, and those that said we're not going to make it a mandated, which doesn't mean that they still couldn't provide it, but it wasn't one of their mandates, did not.
That's exactly right.
Okay, thank you.
Thank you. Any other discussion on the bill? This has been good, because I think that you understand what you're voting for, and we welcome the discussion here, right? This is a safe space, all right? And did we move the bill? I did move it, okay. So the bill has been moved in second. We have had discussion. All those in favor say aye. Aye. Any opposition? Delegate Chisholm, Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, Delegate Kipke. Who does not want to be on the bill? Can you raise your hand? Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. All right, let's move on now to House Bill 970. Maybe this will be a little bit easier. Health insurance, insulin prohibition on step therapy, and fail first protocols. Favorable with amendment, Lisa and Collison.
There is an amendment on page 5 of your packet, and as amended, the bill prohibits certain carriers from imposing a step therapy or fail first protocol for insulin.
Okay, who is it? Vice Chair Collison?
Yes.
Go ahead.
Yes. So carriers already do not require a step therapy, but we just don't know how things might evolve, so this will prevent them from doing it in perpetuity. The amendment and the bill as amended passed unanimously in subcommittee. I move the amendment.
Amendments have been moved in second. Any question or discussion? Seeing none, all those in favor of the amendment say aye. Aye. Any opposition? Seeing none on the bill as amended. Bill has been moved in second. Any question or discussion? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, who does not want to be on the bill, raise your hand. All right, let's move on to House Bill, and Delegate Woods, I love that number, 970. Okay, House Bill 974, Delegate Shetty, Health Insurance Preventive Services Enforcement Authority. It came out of subcommittee favorable with amendment, and the analyst is Lisa, and the chair of the subcommittee, Collison. Lisa.
This bill requires the insurance commissioner to enforce the requirement that each carrier provide coverage for specified preventive services without cost-sharing requirements, consistent with federal rules and guidance in effect on December 31st, 2024. The amendments are on page 6 of your packet. The first amendment is technical. The second amendment specifies that the commissioner must enforce the preventive care provisions of state law consistent with guidelines set by the United States Preventive Services Task Force, the Advisory Committee on Immunization Practices of the Centers for Disease Control and Prevention, or the Health Resources and Services Administration. The amendments also specify that in addition to adopting regulations consistent with federal statutes, rules, and guidance in effect on December 31st, 2024, the commissioner may adopt regulations at a later date to enhance the scope of preventive services.
Thank you, Lisa. Vice Chair Collison.
Thank you, Madam Chair. This bill simply codifies the no-cost sharing requirements of the ACA in Maryland law. So if it should be changed at the federal level, we will have it here in Maryland. The amendments were, no, neither was unanimous, but it did pass the committee, so I move the amendments.
All right, so the amendments have been moved in second. Are there any questions on the amendments? Delegate Morgan. Okay.
On the bill.
All right. All those in favor, thank you. Any discussion on the amendments? All those in favor say aye. Aye. Any opposition to the amendments? On the bill as amended? Second. Is it moved in second? Discussion, questions, Delegate Morgan.
So if the feds wake up one morning and say that they're going to do away with this portion, and then we're passing this bill, then we're stuck picking up the difference? Is that what I'm seeing, that we're stuck paying for no copays? And
Here's the law now.
That's the law right now. So, and it applies to, commercial insurers, so they can't, in Maryland, they wouldn't be able to charge us for preventive services.
So for clarification, right now, the carriers are required to do it.
Right.
They're required to do it.
Federal law.
Yes, and they're doing it. And our constituents are getting that coverage. But if the federal government were to get rid of that, then our constituents will be covered, like they're covered now, and like what they're used to now, that they're receiving that service, so they don't have to pay any co-pays.
So it would be, I guess, what we would classify as a mandated benefit, and the rates would go up. Why? How would this affect rates?
Well, they're doing it right now. So, and the MIA would be evaluating their funds and their rate increases. I'm not sure how they could ask for an increase in rates when they're already doing it, so they can only apply based on their utilization the prior year.
Thank you.
Yeah, and as I like to say, the sky is not going to fall because they're doing it right now. Nothing's going to change. So we were on the amendments. No, we were on the bill. All right, so the bill had been moved in second, and we're in discussion. Delegate Hill.
I just wanted to check with Delegate Morgan. I think you may have been thinking about the basic plan, where when we change our basic plan, we have to pick up the costs. And this is not that. You were thinking we have to pick up costs because is that what you were confused about?
I was concerned that, if they pull this back federally, and then insurance companies would add some type of costs, deterrent or to limit service like a copay, and then we have this bill in place, I'm thinking that would result in a rate increase for our carriers, even though they're currently doing it.
But we don't pay the rates. This is not.
But the ratepayers pay those fees. They pay the copays and they pay the insurance premiums. But they are currently doing it.
And Delegate Morgan, they're currently doing it. Our constituents are getting it. It is required by the federal government. So whatever the premium is that they calculated, it's done.
But
so they're not, right now, they don't have to pay a copay. And all we're saying is, if the federal government gets rid of that, in Maryland, you still have to do it.
Yeah, so I guess what I'm saying is that if you get rid of that federally, some insurers in Maryland would probably offer a no copay plan, while other insurers would probably offer a higher copay plan that would probably cost less money. So to me, it was a consumer choice deal. And then we're locking people into saying, here's the policy prescription that we're going to go through in Maryland, even though that might become available.
But look, they can do that with any of our policies, right? With any of our policies, and MIA regulates the rates, right? They have to submit it to MIA. MIA would then review and see if can they justify that. Tell me what changed when you were doing it, then now you have to change it, right? That would be suspect if I was MIA, because they have been doing it now for years. Any other questions or concerns? Delegate Riley.
Sorry, just from your comment. You
It's
just said,
okay.
thank you, Madam Chair. So basically, I think I hear what Delegate Morgan's saying. So right now, they're currently doing it, so there's no pay, so they're covering it. But if the federal government decides, say, it's not obligated, you're not obligated to do this anymore. So in the carrier's mind, okay, well, we don't have to do this because it's not required by federal government. So that could be savings to them, okay? So they could then cut it out here. And then, so you're saying, well, no, because they could go to MIA then. Well, if they go to MIA, are you saying that MIA would turn down a probable cause of them saying, hey, because we don't have to do it. It's not required by federal law. So we could either save by taking away that particular option, or we could charge more to pay.
But you're assuming that they're going to give those profits to us, the consumer. For example, United, their profit last year, was it last year or the year before, was $22 billion or something like that. Imagine if some of that profit that these companies are making were to come to us, they should be reducing our premiums. So the MIA makes an intelligent decision based on the facts and all of that, even what I just said, to see whether or not it's justifiable. So what we're doing here, and I do welcome your question, is making a policy decision that this saving that our constituents don't have to pay a co-pay right now is important.
Right. I get it. I just, you're saying you're leaving it up to the MIA, and you kind of gave the impression that, yeah, if that scenario came before the MIA, that they would agree
Oh, no,
not
I'm
to
not saying
allow
they
them
agree.
to
They will
stop.
review. They have to review all the facts. I don't know how they would come down or what decision they will make, but at least there's someone that will have an eye on it and we have empowered them to be able to review all the rates, right? When they submit, I think they have to submit their rate, proposed rates. When is it, Lisa? Is it in July, June or July? And then we find out like in September.
But if we codify this and pass this bill, it doesn't even have to go, the carriers have no option to go to the MIA. You've already.
They're required.
Yeah, go ahead.
Madam Chair. They're required every year, every carrier has to submit in June what they think their rate increases need to be for the following plan year. The MIA has the authority to decline and say, you can't, based on your experience, based on what you have provided in terms of claims, reimbursements. Remember, they have that medical loss ratio rule that they only get to spend 20% on administration and the rest has to be on services. So they look at that. And historically, the MIA has often told a carrier, your rates are too high, they have to come down. And they have abided by the MIA.
Right, but they won't have the option to remove this coverage.
No, not if we pass this bill.
Thank you.
Thank you for your question, Delegate Riley. Delegate Shalega.
Thank you, Madam Chair. I'm less concerned with the carrier and more concerned with the patient that's getting health insurance. Is it true that you cannot get a high deductible plan here anymore?
Not that I'm aware of.
I mean, isn't there on the exchange a limit for, you used to be able to get a kind of like a self-insured plan where if you were a small business owner, you could pick a plan that had like a $10,000.
Are you talking about catastrophic plans?
Yes.
You can still get that under certain circumstances.
Well, the bronze isn't what I'm talking about because they removed that option. So
That's
you
what I mean,
can,
yeah.
but it's very limited. It's only up to age 32.
I don't know the details, but I know that
Okay,
your
well-
question was, can you still get it? Yes, you can, under certain circumstances. What are those? I don't know. I'm texting Michelle Everly, who would know the answer.
Okay, so
but I
just-
don't know it. All I know is that you can't get it. I just don't know the details.
Yes. So follow me here for a second.
Absolutely.
So there used to be, pre-ACA, an opportunity to get this more catastrophic plan where you could choose to pay out of pocket for some of these services. So if we pass this, those, let's say the federal government makes that kind of plan available again. That would not be allowed in Maryland. So wouldn't this bill reduce consumer choice?
She said we have a bill here. Go ahead, Delegate Constance.
I'm not following you, Delegate, I'm
If
sorry.
you're saying every policy has to have a zero copay,
No,
isn't that what this says?
it's the ones that are currently, the ones that currently exist.
Yes.
And are abiding under the ACA rules. Yes, those plans, all of those plans would continue not to have a copay for preventive service.
And if I may have Michelle Everly on the phone, there's always a first. She says having no copay does not reduce your choices.
But reduce future choices. So if someone wanted to offer a plan, like there was a company called Golden Rule that used to offer these kind of plans, you know, for those of us that didn't have government-paid health insurance, you know, this is something that we had to know about. So I think what this could do unintentionally is reduce consumer choice on insurance products, because and you know, tell me if I'm wrong, is this saying every new insurance product is going to have to?
The answer is no.
So what is it saying then?
The answer is no, that it does not reduce your choices. You know, different companies choose different plans, right? And it is up to the consumer to decide what their pocket can afford. And they're all very different. But it does not reduce choices. There's different choices out there.
But this bill says that the only choice they can have is a plan that has zero copay. They cannot choose a plan that says you could choose to have a $20 copay. It says every plan offered has to have a zero copay.
Only on preventive services.
Right. Yes, I'm
Right.
agreeing with you.
Okay.
I'm not saying that it's wrong. I'm not saying it's great. I'm just saying, you know, if you want to offer free market solutions in insurance, if someone wants to choose zero copay, go for it. But if a person said, I wouldn't mind having a $20 copay, after we pass this bill, the consumer doesn't have a choice to select a plan that offers that benefit. Is that correct?
I'm not sure that's a benefit, because
Well, but that's your
Right.
opinion, not
Right.
someone else's. I'm saying if someone else made that choice, they can't in Maryland, because this bill is limiting the choice. Be it a good choice, I'm not denying that you like this choice. But you can't choose for everyone, but this bill does.
That would be the choice to pay more for your health care.
Yes. Well,
Right. You're
less
right.
for their premium,
Right.
but more when they went to get that service. So that would be, I think what Delegate Morgan and Delegate Riley were saying is this is reducing consumer choice. Not that we don't think this is a nice benefit, but that you're selecting this benefit for everyone regardless of their choice. Thank you.
Yeah. So it's a matter of choice, right? I guess you could say I want a plan that has a $5 copay or one that doesn't have a $5 copay, but there's still choices, right?
Not when you pass this bill. You're saying there isn't a choice. Everything is zero.
But the same as it is now. Let me just say to you, let me say to you, it is the same as it is now, and we have the 6 carriers, right? Michelle, do you have 6 carriers in the exchange? In the individual? In the individual exchange, we have 5 right now,
Yes,
right?
I understand that.
But
I
let me
guess I'm-
finish,
I'm-
let me
okay.
finish. So you have 5 in the individual exchange right now. Those 5 have agreed to give service in Maryland with this requirement right now, right? If we pass this, it's going to stay the same, and they are still in Maryland doing business and being profitable, right? And offering those services with that requirement right now.
Yes, I understand that. I must be doing a bad job of explaining to you.
I know
that consumer choice, this is limiting consumer choice.
You know what?
Because, yes, they're making it, and I don't care about the profits that these insurance companies are making. I am concerned about consumer choice. So I think philosophically, Madam Chair.
We're going to disagree
we're going to
philosophically.
disagree on
because it depends what choice, right? Like,
Yeah,
if
but-
you're going to get a junk policy that is not going to cover you, and then we end up paying for it at the state when you're not able to pay it, and you end up with debt. I mean, we're going to agree to disagree respectfully.
Yes, I'm not saying it be a junk policy, because many people on the private market do pay a small copay, so they don't have.
Not for the services they're talking about.
But it might be a national plan.
It's
that-
okay. We're going to disagree to disagree.
Thank you.
So I love it. I tell you, this is how the federal government should be, right? Okay, that being said, we did move the bill. We did have a wonderful, healthy discussion. And Michelle, you take good care, okay? Anyway, that being said, thank you so much for bringing it. I get it, and we're going to take a vote on it. All those in favor say aye. Aye. Any opposed? Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Wonderful. Thank you for the discussion. Appreciate it. We are going to go, guess what? 3 more bills. Oh, who does not want to be a co-sponsor? Raise your hand. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, Delegate, okay.
You want to be a co-sponsor.
Oh, and Kipke. And Delegate Kipke. Can I tell you, in my dream, I go Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, Delegate Kipke. Anyway. All right, let's move on to House Bill 1045. We have to have fun. We can't take ourselves too seriously, okay? House Bill 1045, it is health insurance, that pesky health insurance, and family planning services, consumer protection updates. It came favorable with amendment. It is Lisa and Vice Chair Collison. Lisa.
This bill updates references to federal law related to family planning services, grandfather plans, explanation of benefits, summaries of benefits and coverage, medical loss ratios, catastrophic plans, annual limits for cost sharing, prescription drugs, and rescissions to December 31st, 2024. The bill also specifies that the Insurance Commissioner and the Maryland Commission on Civil Rights have concurrent jurisdiction to enforce consumer protection provisions related to discrimination in health insurance. There are 2 different amendments. There is an amendment on page 8 of your packet that was passed by the subcommittee, and this amendment strikes language that would have altered the definition of family planning providers.
Chair Collison.
Yeah. Thank you, Madam Chair. So I would like to take the First Amendment first, and that amendment passed unanimously in the subcommittee, so I move the First Amendment.
So the First Amendment has been moved and second. Is there any discussion on the First Amendment? Seeing none, all those in favor of the First Amendment say aye. Aye. Any opposition to the First Amendment? Seeing none. On the Second Amendment?
Okay, so, Madam Chair?
Yes.
The Second Amendment was not offered in subcommittee.
Okay.
So we're bringing this, and hopefully we'll be able to resolve this in the full committee. It was brought to the attention of the Women's Caucus and the LGBTQ plus caucus that the bill that we passed last year to shield gender-affirming care information and data, and keeping that information private, was not adequate to really shield all of the services that could be provided under the category of gender affirming. So we potentially could have brought another bill in, but it actually fits well into this bill because what this bill is doing is updating some information around family planning services. And in the original bill, the legally protected health care included both reproductive services and gender affirming care. So on page 9 of your packet, you'll see what the amendment says. And it basically expands reproductive, replaces reproductive with the word sensitive. And so sensitive health services, medications, and supplies related to the provision of abortion care, which it is currently in the law, and then reproductive health and other sensitive services as determined by the Secretary. And that is because transgender people have come under attack, serious attack, in the last decade. And there are states that do not allow these services. And there are states that are considering criminalizing these services in much the same way as the abortion care. So what we are trying to do here is protect these individuals from having this information shared in any way that will could potentially cause them harm or criminalization. And so with that, Madam Chair, I would move this second amendment.
Second. The amendment has been moved and second. I'm going to open it up for discussion. This is the place to have it. I welcome it, okay? Delegate Chisholm.
Thank you, Madam Chair. I don't know if Vice Chair said this and I missed it or not. Where is sensitive defined somewhere in our code?
I'm looking to my counsel.
I mean, who determines sensitive?
Sensitive information is defined in the amendment. That's the definition we're changing.
It's at the bottom, and then the second page.
The bottom of the amendment.
Sensitive services includes reproductive and gender affirming care.
Gotcha. Okay, thank you.
Thank you for the question, Delegate Chisholm.
Sorry, I didn't know.
Delegate Hill. It's all right. This
Yeah,
is the
this is,
place. We're not on the floor yet.
This is a question for Lisa.
Yourself some
At the bottom
grace.
of 9, I'm just curious about why it's listed as 1, the provision of abortion care, and 2, reproductive health, as opposed to 1, 2, 3? Like, why is 3 not other sensitive health? Does that change anything? So that you've got 3 things to me: abortion care, reproductive health care, and other sensitive, but they're listed as reproductive health and other are put together as a single one, and I didn't know if that was deliberate or it matters or it doesn't matter.
Give her a minute.
I don't know that there was a reason. I think it could be split up or. It could-
Okay, because later on, we list them. Right, so I just wanted you to take a look at it, that's all. I trust whatever you think is fine.
I suspect that would be technical. That would be a technical amendment. Yeah. Yeah.
So just in case Lisa needs to work on the language, we have it in concept. What it does, let's vote on it as is in concept. It's technical, she can fix that later. Okay, so let's go on to the discussion of the bill. And thank you, Delegate Hill. Delegate Bandari.
Oh, thank you, Madam Chair. This amendment safeguard medically necessary treatment and also prevent discrimination and upholds healthcare rights for all individuals, regardless of gender identity. It's a very good amendment. I would support this.
Thank you. Any other thoughts on the amendment? Any other discussion? Any other concerns? This is the place to have it. All right, seeing none, all those in favor of the amendment say aye. Aye. Any opposition to the amendment? Okay, Delegate I got a me more than the arm. Okay. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke, me. All right.
So, Madam Chair.
On the bill,
I would.
are there any other amendments?
There are no other amendments, and I would move the bill as amended.
The bill has been moved in second. Any questions or concerns on the bill? Any discussion? Seeing none, all those in favor say aye. Any opposition, raise your hand, please. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Thank you so much for the discussion. I appreciate it. Let's move on to House Bill 1082, health insurance. Oh, who does not want to be on the bill? On quite vocal today. All right, who does not want to be on the bill on House Bill 1045? Raise your hand, please. Delegate Shalega? Okay, Delegate, I'm looking out for you. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Thank you. Let's move on to House Bill 1082. Health Insurance Individual Market Stabilization, Establishment of the State-Based Health Insurance Subsidies Program. It came out of subcommittee favorable with amendment. Lisa and Vice Chair Collison. Lisa.
This bill requires the Maryland Health Benefit Exchange in consultation with the Insurance Commissioner to establish and implement a state-based health insurance subsidies program to provide subsidies to individuals for the purchase of health benefit plans in the individual market. The program must be designed to maintain affordability for individuals purchasing health benefit plans through the exchange and target individuals who experience an increase in federal applicable percentages for premiums based on household income in calendar 2026 compared to calendar 2025. There are amendments on page 11 of your packet that extend the individual subsidies program from 1 to 2 years. Add to the factors that the exchange is required to consider in establishing subsidy eligibility and payment parameters to include funding for the state reinsurance program and uncertainties in enrollment, and provide that the bill will become effective on June 1st and that the bill will terminate if federal advance premium tax credits are extended.
Vice Chair Collison.
Thank you, Madam Chair. So this is another bill that is sort of preemptive in a way, that if right now we are receiving additional funds from the federal government under the ARPA bill, which I don't remember what it stands for, and the Congress has to make a definitive process in order to continue those. We want to be ready if they don't continue those, and that's what this bill does. It will supplant the federal funds that we lose if the Congress does not act with state funding. And as the bill came in, it was to use the reinsurance fund in order to supplement the and to subsidize premiums so that people's premiums wouldn't suddenly go up. With the amendments, what the amendment does is it will enable us to stretch out the use of the
reinsurance.
Right.
State portion of our reinsurance, not the general fund.
Right, yeah, right, the reinsurance fund. And what it does is it allows the exchange to sort of dole out the funds in a way that will extend its use. And we have to request our waiver for the reinsurance fund in 2028, so this will take us to 2028. And so with that, the amendment was unanimous in subcommittee. I move the amendment.
The amendments have been moved in second. Thank you, Vice Chair. All those, is there discussion or concerns on the amendment? All those in favor of the amendment say aye. Aye. Any opposition to the amendments? Seeing none, bill pass. The amendment passed. On the bill.
The bill as amended was not unanimous, but it did pass the subcommittee. I would move the bill as amended.
The bill has been moved as amended. The bill has been moved in second. Any questions or concerns on the bill? Seeing none, all those in favor say aye. Aye. Any opposition? Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. All right. Who does not want to be on the bill? You're going to be in my dreams. Go ahead. Delegate Shalega, Delegate Chisholm, Delegate Morgan, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. All right, let's move on to the last bill of the day for voting. For voting. House Bill 1334, and it is Garrett County bids and contracts advertisement exceptions. It was favorable, Lindsay and Kerr.
This is a Garrett County delegation bill that authorizes the county to enter into a purchase or work project contract for an indeterminate amount of goods or services procured on an as-needed basis over a period of time without advertising for bids, regardless of contract value. It also allows the county to enter into a contract for the purchase of one or more vehicles for up to $100,000 without advertising for bids.
All right, the bill has been moved in second, all right? Any question or discussion? Seeing none, all those in favor, oh, Delegate Hill. Delegate Hill.
It's brought up in subcommittee, right?
Excuse me?
And I was asked to give the answer at committee. So I raised the question, since they weren't going to be publicly advertising, what would be the direct public accountability component? So we requested the delegation of the delegation, meaning of the delegate, the answer, and this is what we got. All right, we received. The commissioners will continue to use the same current process of taking 3 verbal bids. The accountability process will still be the same. The county attorney will still oversee the overall procurement process. The process of challenging their procurement decisions would either be done in court or through the election process. And Garrett County purchasing policy requires 3 written bids for any purchase over $5,000, and the proposed legislation does not change that requirement. Additionally, any purchase over $10,000 must be reviewed and approved by the Director of Financial Services. So I took that to mean that they don't have a direct accountability process now other than the advertisement, but they'll continue to do what they've always done.
Thank you so much for looking into that. We appreciate it, and for the follow-up. Delegate Chisholm.
Thank you, Madam Chair. For the record, the chair asked Delegate Hill to do the research, to which she quickly delegated over to council. So thank you, council.
All right, I love it, I love it. Our council are wonderful, right? So all those in favor say aye. Aye. Any opposition? None. So the bill passes. And can you take us down, please? And can you stay in your seats?